After 20 years in neurology, there is one phrase that still stops me cold. I hear it in clinic notes. I hear it in referral letters. I hear it from patients who come to see me after years of going nowhere. That's just normal aging. And every time I read those words, I think, we failed this person. If you have ever sat across from a doctor and felt like your concerns were being folded up and put away, like your memory or your thinking or your fog was simply the price of getting older, I need you to hear this. That feeling you had? That something wasn't quite right? You were not being dramatic. You were not imagining things. Most appointments run about 15 minutes. What gets handed out in 15 minutes is often a label. Not an answer, not a plan, a label. Today I want to pull that label apart and show you what is actually underneath it. Because your brain is remarkably resilient and it deserves more than a placeholder. Let me tell you what normal aging actually means in clinical practice. It does not mean your doctor examined the evidence and concluded that nothing was wrong. In most cases, it means the investigation stopped. Time ran out. The chart got closed. Normal aging is what we call a diagnosis of exclusion. It is what gets written down when a physician runs out of minutes, not when they run out of options. And the difference between those two things is enormous. Because here is what that label does, biologically. The moment a cause is not sought, a treatable condition goes untreated. And that window, that period when intervention could actually change something, quietly closes. I sat with a woman a few years back, late 60s, sharp and articulate. She told me her memory had been slipping for a while. Not dramatically, just enough that she noticed. She had seen 3 different doctors over 2 years. All 3 had said some version of the same thing. Normal for your age. These things happen. A basic blood panel told a different story. Her B12 was critically low. Her thyroid function was off. Both of those things on their own can mimic the early signs of cognitive decline. Together, they had been quietly dimming the lights in her brain for years. We treated both. Within months, she felt like herself again. This is not a rare story. This is what happens when the label lands before the question is asked. The conditions that most commonly get missed, the ones that actually respond to treatment, are not exotic. B12 deficiency, hypothyroidism, undiagnosed sleep apnea, depression, medication side effects. These are not rare edge cases. They are common. They are testable. And every single one of them can produce cognitive symptoms that look, on the surface, like dementia. But they are not dementia. They are medicine. There is a distinction I want you to hold on to, because it matters more than almost anything else I will say today. There is a difference between the brain slowing down and the brain being starved, inflamed, or chemically disrupted by the drugs meant to help it. One of those is aging. The others are conditions. And conditions have treatments. The problem is that normal aging collapses that distinction. It takes everything, the fog, the word-finding gaps, the slow recall, and drops it into one bucket labeled expected. And once something is expected, it stops being investigated. I am not saying every doctor who uses that phrase is being negligent. I am saying the system they are working inside does not give them the time to do better. A 15-minute visit and a prescription pad is not a cognitive workup. It is triage. And when triage becomes the standard, the people who lose most are the ones whose problems were actually fixable. But here is the part that gets skipped almost every time. Not because doctors lack the knowledge, but because the biology itself is rarely explained to the people who need it most. What is actually happening inside the aging brain is far more specific and far more actionable than the label suggests. The brain does not simply wear out. That is the first thing I want you to understand. It does not erode the way a joint does, or slow down the way a metabolism does. It changes in specific, measurable ways. And when you understand those ways, you have real leverage. Think of cognitive reserve as your brain's backup generator. Over a lifetime, every time you learned something new, solved a problem, had a deep conversation, built a skill, you were adding to that generator. The more connections you built, the more pathways exist to reroute around damage. When the main road is blocked, the brain with strong reserve finds another way. The lights stay on longer. This is not a metaphor. The research is clear. Higher cognitive reserve delays the point at which symptoms appear, even when the underlying biology has already started to change. Two people can have similar levels of brain pathology, and the one with more reserve will function better, sometimes for years longer. The reserve does not stop the change, it buys time. And time in neurology is everything. Now, let me explain what happens to memory specifically. There is a small structure deep in the brain called the hippocampus. Think of it as the brain's intake desk, the place where new information gets logged and processed before it moves into long-term storage. When this structure shrinks or slows down with age, something very specific happens. Recent memories feel slippery. You walk into a room and the reason you came in has already gone. You meet someone and their name dissolves before you can hold on to it. But older memories, things from decades ago, those stay vivid, clear as ever. That asymmetry, recent things slipping while old things hold, that is the hippocampus. And it matters, because understanding that pattern helps you distinguish normal age-related change from something more serious. But here is the part that most people, and honestly, most standard checkups, never get to. Your brain has a waste clearance system. It runs almost entirely while you sleep. Think of it like a night shift cleaning crew. They only come in when the building is quiet. When sleep is poor, night after night, the crew cannot do their job. Toxic proteins accumulate, slowly, silently. The fog you feel after a bad night is not weakness. It is a biological waste management failure. And because it builds gradually over months and years, it rarely gets flagged in a 15-minute appointment. This system, called the glymphatic system, is one of the most important discoveries in neuroscience of the last decade. And it is almost never mentioned in a standard visit for memory concerns. Not because doctors do not care, because the visit is not long enough to get there. And that right there is the problem. Not the biology. The biology is actually working in your favor. The problem is what happens when a system built on 15-minute slots tries to address something this specific. Because the gaps are bigger than most people realize. Now, there is one more thing I need to introduce here, because it speaks directly to how often we are getting the diagnosis wrong. Knowing the system is failing is one thing. Knowing what actually protects the brain in spite of it, that is something different. And that is where I want to go next. There is a condition called late dementia, limbic predominant age-related TDP-43 encephalopathy. It affects roughly 1 in 3 people over the age of 85. It progresses more slowly than Alzheimer's. It responds differently to treatment, and it is routinely mistaken for Alzheimer's by specialists, not just primary care doctors. Most seniors have never heard of it. This is not a small gap. This is a diagnostic blind spot sitting at the center of one of the most common fears people bring into my clinic. And it leads directly to the next question, which is not about the biology, but about the system built to address it. Here is a number that should bother you. The average primary care visit in the United States runs somewhere between 15 and 18 minutes. That is the full slot. History, exam, questions, prescriptions, and goodbye. A thorough cognitive workup takes significantly longer than that. So does a conversation about sleep quality, medication interactions, mood, and recent changes from baseline. Something always gets cut, and what gets cut almost every time is the deeper question. Doctors are not cutting corners because they are careless. They are cutting corners because the system gives them no room. When time is short, the assessment defaults to the surface. Are you managing your daily tasks? Can you drive? Do you know what day it is? What that assessment does not ask is whether you are managing as well as you were 2 years ago, whether something has shifted, whether the person sitting across from you knows, in their own body, that something is different, even if they cannot name it yet. That gap matters enormously, because over 90% of mild cognitive impairment cases in the United States go undiagnosed in primary care. Not because the condition is invisible, because the tools to catch it are rarely used in a standard visit. The Montreal Cognitive Assessment is a straightforward screening tool. It takes about 10 minutes. It detects early changes that a brief bedside conversation will miss entirely. And yet, it is not a routine part of most standard appointments for patients in their 60s, 70s, and 80s. What happens in the absence of proper screening? The label lands. And the label, as we talked about, stops the search. And this is exactly where late, that condition I mentioned earlier, becomes so important. Because it is not being caught by brief visits. It is not being caught by standard assumptions. It is being called something else. But the misdiagnosis problem goes deeper than just missing mild impairment. Conditions like late, which I mentioned earlier, are routinely labeled as Alzheimer's. Vascular contributions to cognitive decline, the kind that comes from years of blood pressure that was never well controlled, get missed or lumped in. Depression, which can produce profound memory symptoms and cognitive fog, gets called aging. And the treatment implications of getting those distinctions wrong are completely different. A person with late does not benefit from drugs designed for amyloid-driven Alzheimer's. A person whose cognitive symptoms are driven by depression needs something else entirely. When the label is wrong, the treatment is wrong, and the person keeps declining while everyone assumes the decline was inevitable. There is something else at work here that I want to name plainly because I think it is important. When a doctor expects decline, they stop looking for causes. The assumption becomes the diagnosis, and the patient walks out with a label instead of a plan. I saw a retired engineer a few years ago. Methodical man, precise thinker, the kind of person who notices everything. He had been told for 2 years that his memory concerns were age-appropriate. Nothing to worry about. These things happen. He came to me because his wife had noticed something he had not quite let himself admit, that the changes were getting harder to explain away. The MRI showed something we could actually address. Not something that erased the problem, but something that changed the trajectory of how we managed it. 2 years had passed. 2 years of the window sitting open while no one looked through it. Early detection is not about fear. I want to be clear about that. It is not about hunting for bad news. It is about options. The earlier a reversible cause is found, the more completely it can be treated. The earlier a progressive condition is identified, the more tools exist to slow it. Every month of accurate diagnosis is a month of better directed care. The system is not designed to give you that, but you can learn to ask for it. And that is exactly what we need to talk about next. So let me tell you what actually works. Because this is where the conversation usually gets cut short, and it should not. The most important thing I can tell you about the aging brain is this. Neuroplasticity does not stop at 65. It does not stop at 75. The brain retains the capacity to form new connections, build new pathways, and compensate for age-related changes well into later life. That is not optimism, that is neuroscience. And it means that the biology is far more responsive than the system gives it credit for. Let's start with cognitive reserve, because we talked about it earlier and I want to bring it back here with a different focus. We said it was the brain's backup generator. What I want you to understand now is that you can still add to it. Education, social engagement, mentally demanding work, learning something genuinely new, all of these contribute to reserve. Not in a vague, feel-good way, in a measurable, structural way. New learning builds new connections. New connections give the brain more routes to work with when the primary ones become slower or less reliable. It is never too late to add to that backup generator. Never. Now sleep. We already talked about the night shift cleaning crew, and here is the part that matters most practically. It is not about how long you sleep, it is about the quality. Light, fragmented sleep, even if it totals 7 or 8 hours, does not give that system what it needs. Improving sleep architecture is one of the most direct things a person can do for long-term brain health. And it is almost never the first thing discussed in a standard appointment about memory concerns. Then there is vascular health. The brain uses roughly 20% of the body's entire blood supply. It is an extraordinarily demanding organ, and it is completely dependent on good circulation to function. Blood pressure, blood sugar, and inflammation are not separate conversations from memory. They are the same conversation. What is good for the heart is almost always good for the brain. Years of poorly controlled blood pressure do not just damage the heart. They damage the small vessels inside the brain, silently, long before any obvious symptoms appear. Keeping those vessels healthy is not just cardiovascular medicine, it is neurology. Social connection deserves a place here too, and not for soft reasons. In fact, what I am about to tell you surprises most of my patients, because it has nothing to do with diet, nothing to do with exercise, and yet it may be shrinking the brain's memory center faster than almost any other factor in modern life. Chronic isolation elevates cortisol, the body's primary stress hormone, and sustained elevated cortisol is directly toxic to hippocampal cells. The same structure we talked about earlier, the brain's intake desk, the one most sensitive to age-related change, is also one of the first structures damaged by long-term stress and social isolation. Staying connected is not just emotionally important. It is neurologically protective. It is biology. Physical movement matters as well. Regular aerobic activity increases blood flow to the brain, supports the growth of new neurons in the hippocampus, and reduces inflammation. Not intense training, not a strict regimen, consistent movement, the kind that raises your heart rate and keeps the vascular system working well. What I want you to notice is that these are not separate items on a checklist. They are a system. Sleep supports the glymphatic clearance. Movement supports vascular health. Social connection protects the hippocampus. Cognitive engagement builds reserve. Each piece supports the others. When the system is working together, the brain has real protection. I want to be honest with you here, the way I am honest with my patients. These strategies reduce risk. They slow decline. They give the brain more time and more options. They are not a cure. For some people, the biology will require medical intervention regardless. And that is where the next problem lives. Because even when people do everything right, the appointment itself can undo it. Let me give you something concrete to take into your next appointment. This is not about confronting your doctor. I want to be clear about that. Your doctor is not your opponent. They are working inside a system that does not give them enough time. And the most useful thing you can do is give them better information to work with. You are not fighting them. You are helping them help you. The first thing you can do is track changes from your own baseline. Not from a general idea of what is normal for your age, from your own history. What has shifted? When did you first notice it? Has it changed since then? Write it down before you go in. A single page, specific and dated. This transforms the conversation from a vague concern into a clinical observation. It gives your doctor something to work with that a rushed visit cannot generate on its own. The second thing is to ask for a cognitive screening that goes beyond a brief bedside exchange. The Montreal Cognitive Assessment, the MoCA, is a reasonable, evidence-based request. So is a thyroid panel, a B12 level, a screen for depression, and a conversation about sleep quality. These are not exotic requests. They are standard tools that simply do not always get used without a prompt. You are allowed to ask for them. The third thing, and this one matters, is knowing what to say if you are told your concerns are age-appropriate. Ask one follow-up question. Ask, what would we need to rule out before we are confident that is true? That single question does not challenge the diagnosis. It opens the investigation. It shifts the conversation from a closed door to an open one without any confrontation at all. And if your concerns persist after a primary care visit, a neurologist or geriatric specialist has both the training and the time to conduct the kind of assessment a 15-minute slot cannot hold. Asking for a referral is not an overreaction. It is appropriate care. Now I want to stay with you for just another minute, because there is something I see in my clinic over and over that I would be doing you a disservice to leave out. A patient does everything right. They improve their sleep, they start walking, they ask better questions at appointments, and their brain does respond. Things begin to clear. Then, months later, they come back, and some of that progress has slipped. When we dig into it, the answer is almost always sitting in the same place. A medication, sometimes 2 or 3, that is working directly against the brain, even as everything else is working for it. Drugs that are so common, so normalized in senior care, that no one thinks to question them. Prescribed for one thing, while quietly doing something else entirely to the neurons we have been talking about today. This is not a rare problem. It comes up constantly. And it can quietly undo the very progress you are working toward. The sleep, the circulation, the cognitive reserve, all of it. That is what the next video is about. The specific classes of medication that research has linked to cognitive harm in older adults. The ones that affect the same systems we covered today. The ones that could be working against you right now without anyone having flagged it. It is already on your screen. If what we talked about today matters to you, that is the next thing to watch. Do not leave this half finished.